presentation. This is from Dr. K Manohar, who is a consultant physician diabetologist, Secretary Karnataka RSSDI, speaker in many international and national conferences, and he's also chairperson Disha Diabetes Summit, Medical Director GT Foundation, and Principal Investigator for many clinical trials. Over to Dr. Manohar, please.
At the outset, I would like to thank Faraz for getting us in, and I also wish him all the best for his ventures. So my talk is nicely sandwiched between the cardiologist and the nephrologist, and before in the last session, I think there was a good talk on guidelines and what it says about the choice of therapy. Okay, before I start the session, few questions. How many of us use DPP4 inhibitors regularly? Show of hands. SGLT2 inhibitors very regularly, especially with the cost coming down with the newer SGLT2 inhibitors. How many of us use this combination of DPP4 inhibitors plus SGLT2 inhibitors often? Next, the most important question. DPP4, sir nicely told, the cardiologist clearly explained the importance of SGLT2 inhibitors in heart failure. How about DPP4 inhibitors in heart failure? Are all safe? Are all same? How many of us use DPP4 inhibitors routinely or uninhibitedly in all heart failure cases? People don't use it in heart failure, DPP4 inhibitors? Then some clue to it. Is there a prescription information of use of DPP4 inhibitors in heart failure? Are we aware of it? Any prescription information? Yes. So this would be the roadmap. We'll look at some brief introduction, pathophysiology, SGLT2 inhibitors plus DPP4 inhibitors, and I'm told that we're introducing a new combination of DPP4 SGLT2 inhibitors as Q-turn. What is it? We'll look at it, and I conclude. So everyone knows about it. Epidemiology of diabetes is a growing epidemic. Almost 400 million of us, and 65 to 70 million are in our own country. So someone was jokingly telling, if you want to draw a world map with respect to diabetes, it will also have a central obesity like how an Indian map looks like, and China is not far, and we both together constitute almost more than 1/4 of the patients globally. So we are second in the diabetes capital of the world, but when it comes to the FDC, fixed dose combinations, definitely everyone knows that we are the capital of fixed drug combinations in our country. So 70 million cases and 52 FDCs approved by DCG, and more than 500 brands of them are there. So how is diabetes faring in our country? If you look at this trial, Discover trial, it is an international multicentric trial, studied over 3 years about patient characteristics, the methodology of treatment with respect to diabetes, medications available, and their control. So more than 3,000 of these patients were studied from India, and the mean A1C was 8.6, so we talk about 7, 8.6. I think even in the America it is almost not slightly better than us, not too farly different. More than 45% of the patients who are just on metformin are not controlled, and about 32% of the patients who are on glimepiride plus metformin combination, which is the most commonly used combination in our country, are also not under control. And just to emphasize the inertia what we have, the clinical inertia, both from the physician side and also from the patient side, just to up-titrate the treatment, we take almost 4.6 years to up-titrate a drug. And if you are looking at insulin, it is often 7 to 8 years to the time you think of starting insulin and you actually start. It's almost 7 to 8 years. That's what the alarming picture the study shows. And the famous ICMR INDIAB study clearly mentioned that if you look at the number of patients under the goal of HbA1c of less than 7 is about less than 30% or so. So why is it important? We all know this. Poor glycemic control, risk of complications keep increasing. As we see from 5.5 to 10.5, when we adjusted patient years, the complications multiply. And coming to the most important aspect of diabetes treatment, especially in young and early diabetes treatment, the legacy effect. It is a derivative of the UKPDS study. No talk could be completed without mentioning the UKPDS study anywhere in the world, I feel. So they had a conventional arm who were treated routinely and an intensive arm where the glycemic control were much stricter. So at a certain point when the intervention ended, they followed up the patients for about 10 years or so. If you can look at this graph, the intensive arm who were controlling much better than the conventional arm still had the similar HbA1c as like the conventional arm. But what important aspect it also derives is any amount of complications, if you look at between these two arms, after that intervention is left open, is still much better with the people who are treated early aggressively. So what it says is if you find a diabetic, early diabetic, especially young without any comorbidities, hit hard initially and try to get him to the goal so that even in the future when the control may not be as good because of various reasons, still his risk or her risk of complications are much lesser. So the cost, again the topic comes of cost of treating diabetes and cost of not treating diabetes. As this graph clearly shows, there is an incremental cost when you try to do many things, emphasizing on the diet, exercise, better medications and insulin and monitoring properly. Initially the cost may look higher, but if you leave the person to his own whims and fancies, the life expectancy, mortality, morbidity and the complication cost will be much higher than at an incremental cost what you incur initially. It's like taking a life insurance. You pay something upfront and you work on it. It always keeps you in a better state of life later part of it. So add to the glycemic control, elevated BMI and blood pressure are also equally important, and various trials have shown each 10 millimeter decrease in blood pressure can reduce the mortality and the risk of myocardial infarction up to 11%. And add to that, if they are overweight and obese, which most of us are actually by the WHO Asia Pacific criteria. I don't know if someone can guess whether I am normal weight, overweight or obese. How many are for I am being obese?
You are underweight. You are.
Yeah, I am obese by the WHO Asia Pacific criteria. So please go back and look into it. So we may look, we are the thin fat Indians, or I go one step ahead and say we are thin fat protein deficient Indians. So our risks are much higher. So we should emphasize on weight reduction. So if there is a choice of a molecule, there is for the want of time I didn't put the slide. If someone are starting with two different A1Cs and at the end of 1 year, let's say both have the same A1C, but one group of people have gained weight as opposed to the other group, whatever benefit we give is almost nullified there. So weight gain should be kept in mind, whether the choice of therapy or advocating healthy lifestyle practices is very important. And most important and less talked of is non-adherence. People say we are taking all the medications, they may decide on which to take. You have written it twice, they'll take it once. You tell them to come in a month or 3 months, they come after a year or so. So this itself, this clinical inertia, non-adherence from the patient point or even from a doctor's point of view also can cause increased complications. So by definitely sticking on to the prescription pattern itself can reduce the mortality in a much bigger way than the use of any fancy medications we use. So diabetes management is not just about sugar control, but you look at the weight, manage the comorbidities like hypertension, and look at the safety parameters also. Going on to the pathophysiological approach for diabetes management, DeFranco clearly told, we started from when we were college days, we were talking about just two factors, insulin deficiency, insulin resistance. Now it has come to omnious octate. I had a great pleasure in meeting him once when he was in India, and he was the one man behind SGLT2 inhibitors and giving us the omnious octate. And his theory is, initially we used to talk like stepwise approach of use of diabetes medication. Start with one and build up the dose. And then if it is not exhausted, then add another group of drug and do it. So, but now it is a pathophysiological approach. Multiple drugs should be used in combination based on their pathogenic abnormalities and start early. So it's not like start metformin 2 grams, then add sulfonylurea, reach 4, 6, 8 grams and then add another drug. Try to combine the drugs which are suitable best, of which you are the best judge, and then try to start initially with the same combination. So if you look at the 360-degree approach, which this slide I'm sure would be shown in many of the meetings, omnious octet, if you look at it, if you add metformin and if you add a DPP4 plus SGLT2 inhibitors combination, it almost covers all the pathophysiologic mechanism except from the neurotransmitter dysfunction. So if you look at the wholesome approach of diabetes management, cost and other factors and contraindications not being a concern, a person on metformin, DPP4 inhibitors plus SGLT2 inhibitors would be a best combination to use in most cases. So need for glucose lowering therapy moves on not just from good glycemic control. Look at the combination approach. Now cardiovascular benefits, as the previous speaker was alluding to. Look at the weight gain, hypoglycemia, and many a times it is also known that oral therapies are much better tolerated and the patient's compliance is there because most of our patients are insulin resistant. Means the moment you say insulin, they resist your treatment or treatment approach and they ask us for some more time to get back to you for the start of the treatment. So how good is this combination of SGLT2 inhibitors plus DPP4 inhibitors? So they have complementary action. DPP4 inhibitors require some amount of insulin definitely, even though it also has a good mechanism on the alpha cells with the glucagon. Till the DPP4 inhibitors were launched, we always looked at the beta cells. These are the group of drugs we started emphasizing and we started looking at the alpha cell also. So if SGLT2 inhibitors are there, they're insulin independent. It doesn't matter because it works through the kidneys and it increases glucagon and endogenous glucose production. This is very important to know. This second line where this increases glucagon and DPP4 inhibitors reduces glucagon is very important because we have heard of euglycemic DKA. When you start SGLT2 inhibitors on a person who is on very high blood sugar, which you should not do it, it causes glycosuria, it increases glucagon and it predisposes to diabetic ketoacidosis, even if the sugars are normal. So when they are on DPP4 inhibitors, this will be taken care of and euglycemic DKA is much seen lesser in combination therapy or when these people are using both groups of drugs. And we all know that SGLT2 inhibitors are weight neutral, reduces BP, and other things are. So most important point is because of its reduced glucagon action, the SGLT2 inhibitors which can increase the glucagon, the risk of euglycemic DKA is much lesser. Also later I will tell you how DPP4 inhibitors reduces the risk of urinary tract infections. So complementary mechanism of action, SGLT2, DPP4 inhibitors. Similarly, it works through the gut, it works through the kidney, and a few non-selective SGLT2 inhibitors have an action on the gut also. It works on the incretin effect, it increases glycosuria, weight loss, and indirectly reduces the weight, insulin resistance, improves insulin sensitivity, and add to that the cardiovascular and the renal advantage. It becomes a very, very important combination for us to use. So already the previous speaker spoke on cardiovascular outcomes with respect to SGLT2 inhibitors. I'm sure the next speaker will speak on the renal outcomes. So I'll cut short my presentation here. So we'll look at in a nutshell how the cardiovascular and renal benefits are there when you use both SGLT2 inhibitors and DPP4 inhibitors. When I start this, I would like to say different trials are there. So we can't really compare one trial, like one drug may be better than the other drug based on the trial finding of that drug. To do that, we should have a head-to-head study which is not financially feasible. So apples should be compared to apples and not to oranges. So in a nutshell, CV and renal outcomes with DPP4 inhibitors, if you look at it, hospitalization for heart failure. The SAVOR-TIMI trial is one of the largest and one of the first trials with respect to DPP4 inhibitors which came for CV outcome. So probably they were not aware of it. It was like a chance or a surprise that it showed increased hospitalization due to heart failure. So but later trials what they came in, TCOS and the Carmelina, possibly were wiser and didn't select that group of people. Actually the SAVOR-TIMI trial, if you want to know more, we can discuss it later. It started as a SAVOR trial, but they were not getting events. For a cardiovascular outcome trial, you should have X number of events. Then only the trial stopped. It's not time based. So when they were not getting events, they took a group from TIMI group, which was actually a very high risk group of patients with heart failures. And so possible mechanism is that's how they ended up with heart failure. But the other two molecules did not show that significance of heart failure. But when you talk about CV death, 3-point MACE and the renal outcomes, they were all equally good there. So among the DPP4 inhibitors, there was some sort of a signal with respect to saxagliptin in the SAVOR-TIMI trial that it increases the hospitalization due to heart failure. Rest of them were very safe. As we all know, vildagliptin does not have a CV outcome trial, and teneligliptin also does not have CV outcome trials. When you come to SGLT2 inhibitors, this gray says significant reduction. So when you look at EMPA, reg outcome, canvas and declare-TIMI trial, we can, as I was telling about apples and oranges, it may show that empagliflozin reduced CV death, but those two trials did not reduce CV death. Again, it should not be interpreted like that way because it all depends on the study population. Empagliflozin, when they did their trial, it was all very high risk group. Most of the patients, or almost all of the patients, already had a cardiac event. Canvas program, when they did the trial, they showed 60 to 40. 60% had already had a cardiac event. The secondary prevention was there for most of them, and less number of patients were on primary prevention. When the declare-TIMI trial, they took more population which didn't have cardiac events. So about 80% of the people did not have already a significant coronary issue, and that's why it was more like a primary prevention trial. So when their risk is high, the benefit is high. When the risk is low, the benefit is low. Otherwise, if you look at SGLT2 inhibitors, most of it is a class effect. Reduction of the hospitalization due to heart failure was the most significant thing, which was shown by all the three trials. CV death, 3-point MACE and renal outcomes were also equally good, even though numerically you may find it different. So are there combinations of SGLT2 DPP4 FDCs available in the world, in the country? Yes, already we have the EMPA-LINA combination. DCJ had approved in 2017 and it is already being marketed. And I'm told that recently the dapagliflozin and saxagliptin combination also has been approved and it's being marketed. And now the next in line is ertugliflozin with sitagliptin combination. So again, the past speaker spoke about the guidelines. So now we individualize the therapy. If you want to treat established ASCVD or CKD, or people without those, people who have a higher risk of hypoglycemia, people you are worried about weight gain or the cost, so you classify the patients and then go accordingly. So but wherever you go, definitely you will find SGLT2 inhibitors and DPP4 inhibitors following metformin on the top of the chart, except if you are looking at the cost. So what the consensus guideline says is SGLT2 inhibitors plus DPP4 inhibitor combination. You want to target the A1C reduction of 1.5 or more is an ideal combination following metformin, provided cost not being a factor. So coming to the specific drug combination of saxagliptin and dapagliflozin, that is Q10. Lixambi already is there in the market. Q10 is a DAPA-SAXA combination of 5 mg and 5 mg. Unlike the other combination has 2 dosing, here it is a single dosing. So DAPA-SAXA, of course, before the launch of any molecule, they need to have trials. Pharmacokinetics has to be proven and the efficacy should be matched with the individual drugs, which has been done in this case. DAPA-SAXA achieved better glycemic control with expectedly lower risk of hypoglycemia as opposed to glimepiride. And definitely, as expected, there is a body weight reduction and systolic BP reduction of up to 3.6 millimeter of mercury and body weight up to 4 kilograms. And when they compared this combination as an add-on therapy to metformin, DAPA-SAXA, metformin and insulin, definitely the incidence of hypoglycemia was much lesser as expected, and more importantly, the statistical significance of reduction of A1C was as good as using insulin. Add to that you need to titrate the dose of insulin. Here you don't require to titrate, so it gives definitely an added advantage. And weight loss, as we all know, is an important feature of the dapagliflozin, and that was also shown to reduce about 3.6 kgs, because most of the treatment when we start, there is usually weight gain or maximum weight neutrality, and this combination gives you a better weight loss effect. So when you looked at the side effect profile of all these combinations, as opposed to the individual drugs, Saxa, DAPA combination or Saxa individual with DAPA, importantly the hypoglycemia was not so different, and more importantly the risk of developing genitourinary tract infections were much lesser. So if you look at this row, Saxa-DAPA combination has 3% of genitourinary tract infection, and DAPA metformin had 5.9% of genitourinary tract infection. So 50% reduction of the genitourinary tract infection was seen by adding DAPA, and this was similarly seen in all other studies. If you look at this forest plot, anything point is towards the left favors the SGLT2 DPP4 combination as opposed to the favoring the SGLT2 inhibitor combination. So most of the other trials also had shown that when you add DPP4 inhibitor to SGLT2 inhibitor, the risk of genitourinary tract infection comes down, mainly due to one of these factors, like some of the bacteria and the fungi have DPP4 enzyme on them that makes it virulent, and this gets inhibited, so the risk of infection comes down. So another important trial with respect to this combination is a DELIGHT study, which looked at the renal outcomes of DAPA and Saxa together. So it was a randomized double-blind placebo-controlled study in cases of CKD with albuminuria and eGFR of 25 to 75. It had background diabetes treatment with ACE inhibitor and ARB. On top of this, you looked at adding DAPA 10 mg once and DAPA plus Saxa as the second arm of it. So they looked at the urine albumin creatinine ratio, reduction of the A1C, and also looked at the body weight and achieving the glycemic control. So DAPA Saxa improved urine albumin creatinine ratio much better than what just the DAPA gave. So if you look at this chart, difference versus placebo at week 24, DAPA gave minus 21% reduction of urine albumin creatinine ratio, where DAPA Saxa combination gave a reduction of 38%. So this combination has proven that when you use it together along with the weight loss and the A1C, there is a reduction of the urine albumin creatinine ratio. If you look back, Saver-Timmy trial also had shown that saxagliptin alone also reduces the urine albumin creatinine ratio, and about DAPA, everyone knows that DAPA reduces the urine albumin creatinine ratio. So when we ask this question, we get this glycemic control, we get a better weight management, weight loss, and we also address, even though to a lesser extent, about 3 to 4 millimeter of systolic BP reduction, and safety looks better. The concern was genitourinary tract infection, and the risk also is almost 50% lesser when you use this combination. So this was the point, burning point whenever you talk about saxagliptin is DPP4 inhibitors and hospitalization due to heart failure. What is the issue? Definitely hospitalization of heart failure was higher with saxagliptin. Allogliptin showed a neutrality, but sitagliptin showed no statistically difference between the hospitalization for heart failure. So FDA recommended a label warning initially for Saxa and allogliptin. And they said it is not that it is confirmed, but it requires reconfirmation with further studies. But as you know, as I asked the question in the first beginning, there is a DPP4 inhibitor prescription information for all DPP4 inhibitors, not just saxagliptin, that you should be careful whether you are using sitagliptin or linagliptin. There is a prescription information for us to be careful when we use DPP4 inhibitors in people with established heart failures. You should be aware of the symptoms and keep watchful about it. If you find worsening of symptoms, you should report it. So in some of the speakers, they say when there is a doubt, don't use any of the DPP4 inhibitors. Definitely you can't use Saxa, but other DPP4 inhibitors are also not as safe as we usually used to believe it. So that's one of the most important information I would like to drive. So now hospitalization due to heart failure caution is available in PA of all DPP4 inhibitors. So if you look at DAPA Saxa, or the Q-turn, what they call it as in a nutshell regarding safety, Saver-Timmy definitely showed an increased risk of hospitalization due to heart failure, but that was not their primary objective. So it could be a chance effect. There was no worsening of NT-proBNP, and none of the cases with a good eGFR or a normal eGFR showed any worsening of heart failure. Secondly, they did a large real world studies, 3 of them, and in none of them there were signals pointing towards the worsening of heart failure. And Saxa remains CV neutral. It has proved about the 3-point MACE and mortality is definitely benefited. Questions mark is only on the heart failure worsening. And DAPA definitely, as we all know, all the gliflozins have shown undoubtedly the most important thing is reduction of hospitalization due to heart failure. So to conclude, so when you use these two drugs in combination, especially on a person who is already on metformin, it addresses multiple pathophysiological defect. It uses higher efficacy, 3 to 5 times higher chances of getting to the goal without much of dosage titration is required. Early achievement of glycemic goal, lower risk of hypoglycemia, it improves the weight reduction, and it also reduces modestly the systolic and diastolic blood pressure. SGLT2 inhibitors we know causes cardiorenal protection. DPP4 inhibitors are CV renal safe. Few questions on heart failure exist, and when you use this combination there is a lower risk of genitourinary tract infection, and it all comes in a single pill, and of course with a big cost. So the evolving concept, when we were telling that diabetes has evolved from insulin resistance to insulinopenia, we started looking at FBS, PPBS initially, now the HbA1c came in, then we started looking at the glycemic variability, hypoglycemia, weight gain, but now the center of treatment is cardiorenal benefits. So we moved from just looking at glycemic triad to a glycemic composite. Thank you.